Well, welcome to NCBH Digital Education Series. I'd like to thank Craig Walker and his group for allowing me the opportunity to discuss a recently published paper called The Algorithm for Algorithms of CTO PCI. My name is William Lombardi. I'm from the University of Washington in Seattle. These are my disclosures. I try to be as conflicted with as many people as possible. Hopefully that keeps it even. So one of the things I want to talk about is about how do we prepare for procedures. So in general, when people do procedures, they basically just go in, they do an angiogram, and they do the same thing. And a lot of it is not without really thinking about it. And the reason we end up either having bad things happen or not doing a procedure for fear of bad things is because we're really not prepared. So what I want to talk about is how we avoid procedural complications or how we manage potential procedural complications and using algorithms to be more thoughtful about it. So when something bad happens in the cath lab, most people want to stick their head in the sand. It's called selective ignorance. They then want to go and say, gosh, maybe I should have been a rheumatologist or a dermatologist, or you know what? It's not about doing quote unquote complex procedures. It's about high-risk procedures, so I'm just going to avoid anything where bad things can happen. Unfortunately, that means patients who would benefit will not get a procedure done because of your fear of being able to manage the problem. And this comes to some psychology slides that you can think about and ponder as we go through sort of some of the solutions to technical problems and your abilities to learn. So of all the people watching this digital education series, as much as you might hate it, it's a bell-shaped curve. Unfortunately, 25% of you are the bottom technical ability. And fortunately, 25% of the people watching are the top technical ability. The real challenge is, though, is if you look at the red part of this slide, the perception of your abilities are the most disparate when you're in the bottom corner. So the hardest thing for all of us is to actually look at this and realize, am I in the top corner or am I in the bottom corner? And being open to the fact that we maybe aren't as great as we think we are. And I find it interesting is that those who are actually the best don't actually think they're that good. And so I think for all of us, as we work on the process of improvement and getting better and being able to take on more challenging, difficult, and higher risk procedures, we really need to think about this in our psychology profile for improvement. And that leads us to something called the Dunning-Kruger effect. This is actually psychology, has nothing to do with interventional cardiology. And what it shows is if I have somebody learning something new, that their confidence level is actually the highest of anyone. So if you've never done something and I say, hey, I want you to go do a retrograde through a septal, your confidence level will be the highest in the room of everybody if you've never done it. And as you gain experience, obviously that confidence level gets tempered and comes down. And as you become an expert, your confidence level increases. But what's interesting is the experts have less confidence in their abilities to do things than those with minimal or no experience. And so again, as you think about how am I going to get better, where are you on this curve, and how do you manage this psychology to allow you to actually gain experience, get better, and be successful in your procedures? So what I want to talk about is something that very few people do, and this applies equally to coronary intervention as well as to peripheral intervention, is that most people really don't plan. And if they do plan, they plan for success. They go, oh, I'm going to put a guide wire down, and then I'll put an 035 catheter, and then I'll do a shockwave, and then I'll do a DCB, and I'll be done. But most people don't think, what is the procedural challenges? Am I going to have a challenge penetrating the cap? Am I going to have to deal with side branches? How do I deal with reentry? Do I have an access issue? And so really, if you want to learn to be successful, you actually need to be prepared to fail, understand why you're going to fail, and be prepared with solutions to manage failure rather than only hoping success occurs. And I like to make a fun quote in that, which is, hope and luck are not strategies. And so what you need to do is be prepared. The other is in both of these procedures, you need to realize there's phases and points in the trial. Some things are about finesse. When you're doing a retrograde via an epicardial collateral, wiring that is finesse. When you've got to wire 2 millimeters into the cap and you've got to get the micro catheter to go 2 millimeters without losing guide support and shoving everything out, that's finesse. There are other places that are brutality. Taking a wire and pushing as hard as you can to knuckle it and shove it through a bunch of calcium is just sheer brutality. And sometimes the difference between good and bad is how brutal you're willing to be. The last piece of a procedure is something I call a quantum event, which is the more shots on goal you take, the more likely you are to score. So if you take one shot, you may have a 50% chance of making that goal. But if I have a 50% chance of making that goal and I take 10 shots one time, that means I have a 90% likelihood that I'm going to make it. So you need to know when you're quantum. And when I talk about quantum, septal surfing is a quantum event. The more septals you surf, the more likely you are to cross. Guide extension reverse cart. The more passes you take with your retrograde wire, the more likely you are to get in. The next thing is, very few people understand their challenges because they've been taught by people who don't understand the challenges and who basically have done simple things for simple reasons, not wanting to risk the complications of doing higher risk or harder things out of fear. So it's important to understand your challenge. And also within that is understand your technology. And you need to understand that many of the things you're using are what I would call a me too. A Pilot 200, a Gladius, and a Raider are the same guide wire. You do not need all three. You need one. A Convianza Pro 12 and a Hornet 14 are the same guide wire. You only need one. A Turnpike LP and a Corsair Pro XS are the same thing. You only need one, because just switching and using a different brand is not solving the problem, right? The third piece of this is we rarely do a good job of learning from others. We tend to, academics get famous by basically holding on to their knowledge and protecting themselves. And I had a conversation a long time ago to highlight this. I was on my patio with someone pretty good at CTOs, and we were chatting about this. And they were saying, well, Bill, if I had your skills and I could do what you do, I would never share it with anyone. You have this amazing gift, and for you to stay famous and for you to get all the patients, you need to make sure that you keep that gift to yourself. And my reply to that was, it's not a gift if you don't give it away. And so we really need to do a better job of learning from other people. You will never get better only working in your lab and learning what you know and what you do, because you're in a silo. And going and working with other people or watching at courses, the idea is to have an open mind as to this may be something that solves a problem, or maybe it's not a good idea. But you're not going to know that if you're not open and willing to learn and understand the process. Okay? So the process of that is, if you ask me a question, why do you do that, Dr. Lombardi? I'm going to tell you a detailed answer, either from the physics, from the history of medicine, from pharmacology, or from physiology. But many of the things that you're going to get, and the talk I'm about to do is going to be a little bit of this, which is because. I want you to do this because. Okay? That's not an answer. That's not going to help you get better. So challenge the people teaching to explain why, so you understand the basis of what you're doing and how you got there. The last thing is, repeating the same thing over and over again is not likely to work unless it's actually a quantum aspect of the procedure. And if you don't know what's a quantum aspect and not a quantum aspect, that's an opportunity for education to learn and start asking some of those whys. Is this a finesse? Is this a brutality? Is this problem solving? Or is this quantum? So this algorithm paper came from that background of, we didn't want each person to go out and have to learn the same mistakes that a lot of the CTO people had already made. And what we wanted to do was give away knowledge.
And in this, the people who came up with this had more than a combined 20,000 CTOs and 40,000 PCIs. So these are not people who sit in an ivory tower and stand at the podium and wax eloquent about how great they are. These are people who have been in the lab and worked dedicated for years and years to solve problems. So first of all, we came up with a list of problems. So everybody's dealt with many of these. The wire is across either the proximal cap or all the way across the lesion, but you can't get a microcatheter or balloon to go. I'm sure everybody in peripheral is dealt with. You cannot penetrate the cap. There's just too much damn calcium and you can't penetrate the cap. The question is are you willing to learn new ways to do that? Again, what do you do when the cap is ambiguous? What do you do when the distal cap, and in CTOs for coronaries, it's usually because there's a bypass graft and anastomose in the distal vessel. Other problems are how do you externalize the wire? How do you deal with underexpanded stents? What do you do when a wire will go across the septal, but a microcatheter won't follow to allow you to facilitate working retrograde? Same thing with epicardials. How about the wire gear keeps going into a side branch? And with that, how do I get out of the side branch? Again, these are applicable both to coronary and peripheral, difficult to integrate reentry. Whether you use Outback or Pioneer or the N-tier system, it's still reentry. And how do you channel or how do you deal with a difficult antegrade reentry? For anybody out there who's never gotten pedal access and done retrograde procedures in periphery, you are doing a procedure with your hand tied across your back. And if you're unwilling to learn it, I understand that's your problem, but you really need to learn it and do 30, 40, 50 cases, then decide whether you think it's bad or good. But don't criticize something that you've never done. Okay, that's a common theme in our profession, and which is unfortunate because realize everything you're doing in a cath lab, doing angioplasty, putting in stents, putting in drug-eluting stents, doing reverse cart, doing pedal access, using DCBs, every one of these things at some point, the person who came up with the idea was told they were batshit crazy and that what they were doing is dangerous. And, Andreas Grunzig was laughed out of places because it was so bad. Excuse me. My original training was actually in beta blockers before they were approved for heart failure. And I can tell you that my mentors were laughed out of meetings because of what they did. I used to be called crazy because I would wire septals and go retrograde. Now everybody or many, many people do it. So keep an open mind that when you say, that should be done, don't say that until you've done 10. And if you can't do it, then realize you need to learn. Don't criticize it because you can't do it. Learn how to do it and get better. So we'll go through these fairly quickly, and they're a little bit, I won't read all of them. You can read it. These are common problems, but I'll handle a couple of them. So one, wire across, gear won't follow. Number one, increase guide support, use a guide extension or an anchor balloon. The other is if you have the wire across and you had picked a bad guide, trust that you can rewire it. Think about pulling out, say you went 6 French from the wrist and you're using a JR4 guide, okay? Bad idea. Think about using an AL1 from the wrist, maybe go 7 French, or even switch and go to the leg and start over and put an 8 French guide. It's okay. It's okay to say that I made a bad choice. It's not okay to insist to continue with that bad choice. The second is don't run 7 low-profile micro balloons across, right? A 1.0 balloon is the same as a 1.25 is the same as a 1.5. We can talk subtleties till we're blue in the face, but in the end, you don't need all of them. And if the first one doesn't go, the next 3 are not likely to go. If the balloon won't cross, I would tell you is rupture it. And that means to blow it up till it explodes. And the concept of that is you're actually trying to dissect the proximal cap. Don't be afraid of dissections. You can email me and we can talk about it. But dissections, both peripheral and in the coronary, are way overblown and people are way concerned about it based on a history and fear that they don't understand. Okay? You can use the laser catheter and realize the laser may not go all the way across, and that doesn't matter. what you're trying to do is frac. What you're trying to do is cause dissections and soften the plaque. So lasing and lasing on contrast at the proximal cap, just trying to change the compliance of that cap is an effective way. Again, other aspects to solve this problem. For an impenetrable cap in coronaries, the favorite one we like to use is BASE, and that's balloon-assisted subintimal entry. What that means is I'm going to find a lesion proximal to the proximal cap. I'm going to take a short NC balloon at 1-to-1 size. I want the balloon most likely to dissect the coronary. I'm then going to use a polymer jacketed wire to get in that dissection, because polymer jacketed wires are better at getting in dissections. And then I'm going to make a big loop, and I'm going to go around the proximal cap. And then I'll work on the reentry on the backside. Again, for peripheral, that's ADR, Pioneer, or Outback. Pick the one that you're good at. Or I can do a reverse card from the retrograde. Other option may be scratch and go. What that means is taking a really stiff wire, scratching into the wall of the artery, proximal to proximal cap, barely getting the microcatheter into the wall because you don't want to go out of the wall, and then trying to get a knuckle. And then here are a couple of other solutions that you can do it. If you don't understand these concepts, email, we can talk about it. I didn't show all of the different things for this. I just wanted to give you the concepts. But these are the things, if you don't know what I'm talking about, these are your educational gaps. Doesn't mean you're a bad person. It doesn't mean that you can't do this stuff. It means you need to learn, and you need to be open to the process of learning. How do we deal with proximal cap ambiguity in a coronary? The simplest way is to go retrograde and run a wire or knuckle up and just put a marker there. Because if I put a big marker there, it's easy. You know where to go. Most of the wires we have will penetrate the caps. If you know, IVUS guided puncture can be effective, though very challenging to learn, especially if there's a lot of calcium or a stent across the side branch you may not be able to see. Again, scratch and go like we talked about, base power knuckle, and really if you're desperate, a CTA or CTA overlay could be very helpful, and peripheral, I think that would probably help a lot. Again, distal cap ambiguity, I don't know enough about peripheral because I don't do it, but is a common problem in post-CABG patients when we go retrograde. And a lot of that is just because the vessels are so tented by the bypass, or that the wires go up the bypass graft. So these are solutions to managing bypass graft ambiguity. Again, maybe not as applicable to peripheral, but in coronary, you've got to have, sometimes you can't get the wire to externalize. I tend to use an R350 to externalize. The reason being is it's 012, so it's a better rail than the RG3, which is 010. It's also night null, so it's kink resistant. RG3 is stainless steel, so it can kink, and there have been problems with that. So I tend to use R350. However, RG3 is more deliverable. So if I can't get the R350 out, I have a few RG3s I saved just for this to externalize. If it doesn't work, there are other solutions. And again, this is the key, is have a solution. Don't get stalled. You don't want to spend an hour trying to do the same thing over and over and over again. Be flexible in your decision-making. How do we deal with underexpanded stents and coronaries? So realize right now in the US, 14% of stents placed in coronaries, or excuse me, 14% of PCI in the US. So of all the PCIs in your lab, on average, 14% are currently for restenosis. Realize that 92% of restenotic stents are because they were underdeployed in the first place. Okay, so there are two lessons for you to learn from that. Number one, if you're not doing image-based stenting right now, you are harming patients. The data is very clear that image-based stenting, either with IVUS or OCT, reduces restenosis rates 50%, MI rates in the next year 50%, and reduces mortality related to those events. So the simplest and best way, do the job right the first time. Take the 3 minutes, grab the 1.7 RVUs, stick an IVUS in, look at the size of the IVUS, and actually put an appropriately sized stent in. If you're dealing with an underexpanded stent, you must image. I would tell you in my book, and I would do this anywhere in the world, if you have an underexpanded stent and you do, or if you have a restenotic stent, a restenotic stent, and you do not image it, that is a criminal event. Because all you're doing is perpetuating what the first person did wrong. Learn, get better, understand. Listen, I spent 14 years saying we should not, it's a waste of time. I can tell you in the last 2 years, I was a horrible doctor because of that. On average, my stents were 0.6 millimeters in diameter. Again, that's a 50% difference in restenosis because I wasn't appropriately expanding stents and sizing them. If you have to deal with someone's mistake of putting in an underexpanded stent, shockwave is the best therapy, and you can use peripheral shockwave in coronaries until we get the coronary device next year. Yeah, lasing on contrast, you're trying to frac the material outside. It's better to do this when the laser is somewhat occlusive. You'll get less air emboli and no reflow. And the other is be really, really slow. Again, high pressure balloons, I prefer to use angiscores and cutting balloons. In this situation, one, they don't watermelon seed, and two, they actually are more non-compliant than a non-compliant balloon, so they can help get it out. Occasionally, I have to remove the stent effectively with rotational or orbital atherectomy, and we've had several cases where we just gave up and went around the stent and crushed it. Probably not applicable for those of you doing peripheral, but again, you will have episodes where the wire will go across, but you can't get the collateral to go. And again, understand your problem, understand your devices. Again, a Corsair Pro XS is the same as a Turnpike LP. You don't need them both, but understand your equipment. Same thing, probably not many of you doing epicardials. That's probably not unwise. Another common problem is you'll go into side branch. So one, wire redirect with a stiff jacket wire. That's a Pilot Toiler, a Gladius, or if you like Teleflex, it's a Raider. They're all the same wire. If you carry Pilot, Gladius, or Raider in your lab, you're an idiot. Just take one of them because they're all the same wire. I can tell you in our lab, we go through our inventory every 6 months and throw away a bunch of Me Too's because we collect them like pack rats. And the other is, ensure your decision tree if you don't use Me Too's. Make big, decisive decisions. You can knuckle either with a Pilot, Gladius, or Raider because they make a bigger loop. And the idea of the bigger loop is the bigger the loop, the more likely it is to stay out of the side branch because side branches are usually smaller and will help you get past. The key with this is you have to be good at reentry techniques. Which means you got to be good at doing some form of antegrade reentry or some form of retrograde reentry. You can do a Carlino. What that is go into the CTO body and hydraulically dissect the vessel. And all you're going to do is hopefully dissect a plane, and hopefully it will outline where the vessel goes. And if you know where the vessel goes, now you can switch to stiffer wires to redirect out of your side branch, get past the side branch, and then get back to work with most likely doing some form of reentry technique. So all of these are different solutions to a problem. When you're doing reentry, you're going to have challenges. I'm sure you have them in peripheral, though probably not as much because you probably don't get as much hydraulic filling because usually your sheaths and quote-unquote guides would, in theory, plug the holes. But if you do, there are ways to deal with it. You can move to a place that's less compressed. You can use stiffer wires. We don't use the Stingray wire to do reentry for ADR anymore. I basically use the Stato 820s because it's a stiffer, sharper wire. You can do forms of straw, and there's a bunch of them. I'm not going to go through all of those. But the idea is effectively you're going to suck blood out of the subintimal space to open up the distal vessel in a way that facilitates reentry. And the others, again, you can go retrograde. And the last maybe is you may not be able to go retrograde. You may not be able to do Stingray. So you need to know how to do STAR or SPAM, which are techniques to take failure and turn them into success. And I'm sorry if you don't know the techniques, it's okay. This isn't meant to do that. Email me or call me. I'm happy to explain it or show you some other cases. In difficult retrograde, same thing. If you're coming up from a tibial vessel and you don't know what's going on, use an IVUS and let the IVUS help you decide, should I use a bigger balloon antegrade? Is the problem that I've got one wire true and one wire false and I've got to figure out how to get one from one space to the other? and again, change your position. People tend to get very focused longitudinally at either the proximal cap or distal cap. Look at moving through the vessel body. So what I'd like to leave you is a quote from Russell Wilson, the quarterback of the Seahawks, which is, separation is in the preparation. So think about, as you're looking at your professional career, how much time do you spend actually getting better at intervention, whether that be peripheral intervention or corner intervention? Do you spend more time working on your golf game, fishing, being a better husband, bike rider, pianist, whatever it is? We spend a lot of time. But realize you won't get better, and if you don't get better, you can't treat more patients. And as you've probably seen earlier in these sessions, the care variability of coronary and the care variability of peripheral has nothing to do with the indications. It has all to do with your technical ability to manage risk and to solve problems. Okay? And you can't realize, even for myself, I talk to people all the time, my goal has never been to be the best coronary operator in the world, and I don't even know if I am, and I don't really care. I got into this 15 years ago now for one simple purpose. I wanted to be better. If any of you watched The Last Dance with Michael Jordan, Jordan's goal wasn't really to be the best. He just wanted to be better, and the process of being better he knew would make him the best he could be. That's the concept you need to get to. This is not about you being the best in the world. It's about you being the best that you can be. And to do that, you have to develop the joy of the process of being better. And you can't get better if you aren't open to learning. So don't point fingers and say that's stupid or I can't or blah, blah, blah. Learn. Learn it for yourself, understand it, learn how to apply it. And realize that the biggest issue here is not really the indications. The reason you don't do procedures in the coronaries and the reason you don't do procedures in peripheral is fear. Fear of complications. Something bad might happen. The medical staff office might criticize me. My cath lab staff might criticize me. My partners might criticize me. The surgeons might criticize me. We've built a culture that really enforces people to not do the right thing because we love to criticize and make people afraid. What we need to do is actually change that conversation into it's about the indication and about getting better, and complications are inevitable. If you don't want a complication, go be a radiologist, go be a general cardiologist and read echoes. But if you're going to be in a procedural specialty, complications will occur. What you want to do is learn from them, learn from others, and get better so that sometimes a complication is not a big deal because if you know how to manage it, in the end, it has no consequence. And at that point, is it really a complication? With that, we put together with the guys at CRF a complications only course. It's for coronary and structural. It's not yet for peripheral. We're going to have it. We canceled it this year, but it will be next summer in Seattle. This is a 2-day course. There's almost no trial data. This is all clinical experts showing very specific, a wide variety of complications, showing their complications, and discussing their algorithm for how they solve that problem, and also all of the other options that they may have learned since or thought about to try and either prevent or to manage that complication in future. With that, I hope you enjoyed this discussion. I hope you enjoyed the digital education series. And Craig, thank you again for always including me. I really appreciate the opportunity.